Good evening, everybody. That's a little better, but thank you. Thank you for being here tonight. All right, so tonight we're doing something that we've only started doing at the end of last year. It's called MS Conversations Now. And before I even tell you about the program, though, I want to thank two of our supporters. That's Genentech and Novartis, all right? They made tonight's program possible, and I hope that you could all thank them. Give them a round of applause, yeah. Great, okay. So MS Conversations Now. So on your tables, there's an agenda, all right? It looks like this. Everybody's got one, all right? Or not everybody, but every table's got one, okay? And all we're asking is that you listen to the conversation that's happening up here. So Dr. Steingo and our MS champion, okay, will be speaking with each other about these different topics. And then Dr. Steingo is going to look at you guys, and he's going to say, what questions do you have? And I know you're going to have questions, all right? But somebody's got to raise their hand first and say, I want to be first. I want to be the one that starts this off, all right? Certain topics, we're going to ask 5 questions. Other ones, we're going to ask 3 questions. And we're going to get through the list of different things to be discussed, all right? Again, they're going to speak with each other. They're going to turn it to you all. We want you to ask questions. And we're going to do this for about 50 minutes. After that time, we're going to end this portion of the program, and then we're just going to do a general Q&A for about 35 minutes, okay? And then after this whole conversation is done, MS Conversations Now is this portion of the program is finished. We then have Jeffrey Siegel, who will be up here. Jeffrey Siegel is a personal trainer, and he'll be up here to work with you all and get some of you to come up here as well. We'll discuss Jeffrey later on. So in the meantime, let's get started. You guys know what you're talking about? So we got Dr. Steingo and we got Jill Mollberger, and they're going to speak with each other, okay? So let's get started. I'm going to get out of here. Thank you.
We're going to start talking about MS progression. So Dr. Steingo, what can you tell us about that?
Hello, everyone. So this is going to be a mixture of us in an office visit, but in doing a lecture as well. It's kind of like a hybrid combination of things. I think if you have some questions on a particular topic, you can ask them. There is some time at the end, but if there is something that has to be defined when we're talking about it, go ahead and join in our conversation. Some of the answers that Stuart wants me to do are trying to be short answers. Some of the topics that we discuss could last us in a 6-hour seminar. So we'll try and answer the question in a way that brings out the best value for that question. The first question that Jill asked me is talking about progressive MS. So the question really is words with MS. There are different types of MS. The commonest type of MS, as everyone knows, is called relapsing or remitting MS. Actually, we're changing that name. We're going to call it relapsing MS going forward, rather than relapsing or remitting, because the word remitting is what we could use in cancer. If you have cancer and you're free of cancer, we say you're in remission. But you could have relapsing or remitting MS, and you say you're not having attacks, and then we look at your scan and you see new lesions. And we don't like to use the word remission with MS. It's a disease that's ongoing. So we are tending to use the word relapsing MS. And we know what happens to people with relapsing MS when they're untreated, because we have only had drugs approved by the FDA for MS for 27 years. The first drug approved, beta-seron, was in 1993. And before that, we had no drugs. So we knew what happened to people that had MS without treatment. They would get worse. In fact, in about 15 years after the diagnosis, 50% of people were worse. Now, if you take the fact that most MS people start at a young age, between about 20 to 45, and you add 15 years, they're now only in their 30s or 40s or maybe early 50s, and they're worse, 50%. And after 25 years, 80% of people had worsened. So this is a word to think about, is worsening or progression. And the next word that comes up is progressive. And that is because we have spoken about the relapsing type of MS, but the other type of MS that about 10% of people start out with is called primary progressive MS. Progressive, it means it progresses from the very beginning. There are typically no remissions, typically no relapses or infrequent relapses, but the disease progresses from the onset. That is called progressive MS. So we have relapsing MS, which can progress, and that becomes secondary progressive, or you start out from the very beginning with progression, which is called primary progressive. And so we know that people that are untreated, in general, are going to progress. Just recently, within a recent week, there was a paper published on pediatric MS, which is MS in children. Yes, MS can occur in children as well. Even though the typical age of onset may be 20 and up, MS can occur in children. And in pediatric MS patients, they looked at what happens when treatment is delayed. And the children who were treated later, who had a delayed onset of treatment, progressed and did worse. And we know across the board from all trials with MS that if treatment is not started early and appropriately, that there is always going to be a risk for progression. Let's just look at one other topic to do with progression, which is a very important and big topic in MS now, which is what happens with MS and aging. We have an MS population now because our treatment is so much better than it was 25 years ago. We have an aging population. The average age of an MS patient is now 55. So we have an older population. So when people with MS are at the older age groups above 55, we consider someone above 55 to be an older MS patient. The immune system has aged. The side effects of the drug are more. And more importantly, there could be progression because of other factors. That includes aging. That includes heart disease, hypertension, diabetes. All these things, musculoskeletal problems, are happening as people age. So when an older MS person says, I am aging, we must look at that. It's not always the MS. In fact, it often isn't the MS. There are other factors. So treating the MS is part of a comprehensive management of the whole person and all the other conditions. A little summary there of relapsing, progression, and progressive MS.
What can a patient do to slow progression?
I kind of referred to that. What can a patient do to slow progression? The first thing is be on treatment depending on the type of MS. So we do have now drugs for all types of MS. This is the great news. We never had until a few years ago, but we have drugs for all type of MS. And the majority of people need to be on a treatment. Now, there are some people that are very fortunate. They have what we call benign MS. That means after about 10 years, you can hardly tell that they have MS. Maybe you can't tell. They are very benign. Their exam hasn't changed. The scans haven't changed. They're doing very well. We might call that benign MS. That's a small group of about 10%. And then at the other end of the scale, there are some people who might have what we might call malignant forms of MS, very severe MS. Within a few years, they're chair-bound, bedridden, don't respond to any of the drugs. So those are two at the outside of the bell curve. But for the majority of people in between, to slow the progression of the disease, and I think we'll talk about that a little later as well, is to treat the MS. And already I've also referred to treat the whole person, treat other conditions, exercise, diet, and things like that. So it's a whole comprehensive plan that's involved to slow down this progression.
And how do you determine physical and or cognitive changes in MS in terms of progressing?
How do we determine, well, I guess I don't repeat it because they can hear your question. All right, so how do we determine physical and cognitive changes? Both very important. In fact, the commonest cause of disability in a young person, by far the commonest reason that a young person leaves the workplace is cognitive changes, because you cannot replace those. So if somebody can't walk, they have weak legs, they can't stand even, their legs may even be paralyzed, they can hop into a chair or a scooter. I have several patients who do that. Drive to work in a van with hand controls, go to work with the scooter. However, there is unfortunately no wheelchair for cognitive problems. So when there's a loss of memory, then there is no replacement of that. It's very disabling early on. So this is something often that will come from a patient, from a person's family, and sometimes we may have to do special testing to determine cognitive problems. Often this will be something that becomes evident at work, but as a common cause of disability in a young person. In terms of memory testing, this is very important when someone is looking for disability. When someone is applying for disability, it's very important to document the memory problem, because if we write a note to the disability carrier or Social Security and say that Mr. X has a memory problem, that doesn't count if we just say it. It's important to document it. But if you are not applying for disability, it's less important to do the testing because it doesn't make a lot of difference. If you say you have a memory problem, we have to deal with it. And how do we deal with it? Not very easy. There are work considerations. There's no good drug for a memory. The drugs that have been tried are drugs that are used for Alzheimer's disease. They don't work for Alzheimer's. They don't work for MS very well. So when you have memory problems, it's important to stress and emphasize mental stimulation and physical exercise. Physical exercise is very important for mental well-being. The physical part of it might be more obvious. That's basically, how do we determine that? By your symptoms, you report to us how you're walking, how your strength is. If you have numbness, all your physical symptoms, we examine you, and we do MRI scans. They tell us also part of your physical makeup. So between what you report, what I examine, and what the scan shows us, we have these three, the triangle, the three corners of the triangle that tell us about your progress and how you're doing. And those are the things we can evaluate at each visit to determine how you're doing.
Other than memory issues, what other cognitive functions might someone notice declining with progression?
Yeah, MS can affect memory in many ways, but one of the common things is processing speed and ability to process is slowed down, and multitasking. So many cognitive tasks could be affected, such as paying attention, concentration, speech, expression, memory. There are many cognitive tasks that could be affected, but important tasks are processing and multitasking. Those particularly are affected.
And how about executive functioning?
Yes.
Would you consider that also a disability that people have?
Yes, absolutely.
Anybody here have any issues or questions they want to talk about in terms of progression? Don't all jump at once. Okay? Did you want to add anything else, or is that good?
It's enough for that section. I mean,
Okay.
you can go on all night if you want.
Now, we
It's a
have
huge
an
topic.
issue about
Wait, we have a
understanding.
question.
Oh, do we?
Yes, we do.
Where's the mic?
You have a question?
Yeah, but obviously I
Oh, you tell us. You give us the question. We'll repeat it.
Okay. I wanted to know how you felt about doing different types of puzzles
Puzzles?
and different things that you really like to stimulate the brain, if you felt that those would be helpful with the cognitive ability.
So the question is our opinion on mental types of mental stimulation. For example, doing puzzles. I think all forms of mental stimulation are important, whether it be word games, crossword puzzles, jigsaw puzzles, reading books. I think all kinds of mental stimulation, being part of a dialogue, going to a meeting like this, education, knowledge is power. So learning new information if you can, all these things are very important. I encourage people to come to meetings and to try and learn new things, because that's very important. In addition to that, physical activity is very important. They've shown this well, and they've done this in not only amongst MS patients, and it has been done in MS patients, but they've done this even in nursing homes with people with Alzheimer's disease, where they've compared groups of people, those who are inactive and those who are active, doing exercise. And the group doing exercise mentally is better than the group that doesn't exercise. So physical exercise that you're going to hear about later on is something that's very important too. So how do you try and conserve or slow down the wasting of your memory with mental stimulation, whatever it might be, all forms of it, dialogue, being actively involved, and then also with physical activity.
Any other questions?
Now you can also do physical activity, and Jeff might, I don't know if he's going to talk about this. Have you all heard about NEAT, N-E-A-T? Who knows what NEAT is? NEAT. You know what NEAT is? Tell us about NEAT.
Isn't that an allergy testing?
No, not allergy testing.
Oh,
This is MS department, not allergy testing. No. NEAT.
is it an
NEAT
acronym?
stands for non-exercise activity. So listen to what I've said, non-exercise activity. So you're doing activity that's not based on exercise, and the T stands for thermogenesis. So it's non-exercise activity thermogenesis. For those of you who like to read on the internet, read up about NEAT. What NEAT is saying is that maybe sometimes you can't always exercise. It's hard, you're fatigued, it's tough, but try and be active. Just sitting down, move things, do things, gardening, other activities that produce a form of exercise. N-E-A-T, NEAT. Non-exercise activity thermogenesis is very important. It's saying try and be as active as you can. Besides physical activity on a regimented basis, being active in other ways is also something that is important to do. That's what NEAT is.
And how does that impact that physical movement? How does that impact your cognitive abilities?
It's part of, as I was saying, how important physical activity is to maintain cognitive function. I think it would also be something important.
Okay.
Okay, any questions out here? Oh, keep going, guys.
Okay. We talked mostly about MS symptoms being physical and cognitive. Do you have anything additional that you wanted to add about that?
I mean, we could talk about, so some of these questions you might have listed for later on.
There's
But
a lot
I'm
of
going to
overlap.
talk about the three-part approach that I have to MS, which comes to answer this question in a way. When you're considering treatment of your MS, there are three departments that should be addressed at the visit. One might be more important, the others might not be important, but at each visit there are three potential components that I look at. The first component is treating the disease itself. We spoke about that already. How do you treat the disease itself? Oh, we can't compete with food. Anybody try to compete with food? You never won. You're always a runner-up. Okay, so the first component in managing your MS is the disease management, which we alluded to earlier on, the disease-modifying drug to try and manage your MS, to treat the actual disease. The second component of treating your MS is to treat your symptoms. We call that symptom management. And the third component is what you do for yourself, and we've spoken to some degree about that already. Exercise, physical activity, mental stimulation. So there's always three components that could be addressed at a particular visit. That's why MS is a very complex thing to deal with. So Jill asked me about symptoms, and we spoke about some symptoms, physical. Well, this is the symptoms of MS are huge. There's a huge amount of symptoms. We call this, and in the program that I give that you've seen called The Land of MS, I refer to this as the symptom tower, because there are so many symptoms. If you think about any part of the central nervous system, MS can affect things. It can affect strength. It can affect walking. It can affect bladder. It can affect bowel. It can cause pain. It can cause numbness. It can cause visual problems. So there are a large number of symptoms of MS that we have to consider and deal with at a particular visit.
Let's talk a little bit about MRI and brain health. Do you consider MRI a biomarker of MS? And how so?
No, it's not a biomarker. So in terms of MRI scans, let's just talk about that briefly. MRI scans have been around, looking around, most of you have been in the era of MRI scans. MRI scans have been around since the early 1980s, used for MS. MRI scans were a massive advance in management of MS, because before that it was hard to diagnose MS. CAT scans for MS are a waste of time. They don't help us at all. But MRI scans were a huge advance in diagnosing MS. So that's the first thing we learned about MRI scans. They help us to diagnose MS. Number two, they help us to monitor how the MS is doing over time. How is someone responding to their treatment by virtue of the changes on the MRI scan? And number three, MRI scans were hugely important in research to help us understand the benefits or lack of the benefits of a drug. So MRI scans have been important in many, many ways. Let's go to the second part of your question, is MRI scan a biomarker? A biomarker is some kind of measurement that tells us what type of disease you have or how the disease is doing. Unfortunately, the scan doesn't entirely tell us that. It's a partial marker. We can't pick someone's scan at one point in time, even, for example, and say what kind of MS they have. We can't even tell whether they're doing well or not. We see people that have scans that are severely involved and they look fine, or people that have a low number of lesions, but because of the location in the brain, they may be severely disabled. So the scan is not a complete biomarker. In an individual, over time, the scan will help us. If there are new lesions on the scan and the scan is progressing, then that person may be in trouble. If someone is newly diagnosed and the scan shows a lot of lesions, that person will be in more trouble than the scan that shows less lesions. So the scan helps give us a lot of information, but it's not the full picture and it's not a biomarker. It doesn't tell us what kind of MS that someone has.
Is there some other kind of test that will tell you that information? What kind of MS, what medications will work best?
No. So at this point in time, we do not have a test that we can do that will tell us what kind of MS you have and how you're going to do, or what drug you're going to respond to. We want to know these things in the future. What kind of MS is it? Which drug is going to work? What's the outcome of the MS? This would be nice if we had blood tests that could do that. We don't have that right now. We have things that give us some clues, but we don't have an actual marker in the brain, in the spinal fluid, or in the blood. But we're developing some. And so there is something called neurofilaments light, like the NFL. NFL we call it. Neurofilaments light, and it's measuring certain breakdown products from certain nerve fibers in the brain and the spinal cord, and these nerve fibers may be released, and we can measure the level of nerve fibers, and that may in the future give us some indication. We know that if they're high, someone's disease is active, and when we treat them, that their nerve fibers are lower. This is called NFL, for those who want to look it up, neurofilament light, NFL. NFL are also released in other diseases. But in the future, NFL may be something we could use as a marker for us to measure the response of how someone's doing with their MS.
What about spinal taps? Are those still used?
Spinal taps are used occasionally. We certainly have much less need for them now than we used to have. In most people, their clinical picture and their brain scan is going to give us a good indication that they have MS. Sometimes, if we're in doubt, we will do a spinal tap, especially in primary progressive MS. But in relapsing forms of MS, occasionally a spinal tap will give us information. The findings on a spinal tap are not absolute for MS. Other conditions can have similar spinal fluid findings. Also, when we diagnose MS, remember one thing, there's no absolute, we've just said, there's no absolute biomarker or test for MS. I can't say, I think you have MS, we're going to do a blood test and it's going to prove it. I can't even prove it on the MRI scan. There are many conditions that mimic MS. Very important. Many other autoimmune diseases, like lupus, for example, or other diseases like Lyme disease. Even migraine may cause changes in the brain that could be mistaken for MS. And in older people, aging causes white spots on the brain. So it's very important when we consider MS to rule out other diseases that can mimic MS. Always important. In fact, in our diagnostic criterion, someone is newly diagnosed, we will run a battery of tests to rule out conditions that mimic MS.
And that's how you would do it, with a battery of tests?
Yes, we would do the MRI scan. The spinal fluid we usually don't do. It would be something I uncommonly do. And then we do a battery of tests, blood tests predominantly, and we would look to rule out the mimics, other conditions that could mimic MS.
Does anybody have questions?
I'll be there in a second. There's a question from the back that wants to know what recommendations for how many MRIs they should have, and I can't read her writing.
All right. The answer to the question in part is there's more coming.
Yes.
What's the recommendation for how many MRIs we should be exposed to? Example, every 6 months, every year, every other year?
I mean, MRIs don't do you any harm at all. MRI is not a CAT scan. MRI uses magnetic radiation. It doesn't use radiation like a CAT scan. There is absolutely no proof at all, zero proof that an MRI scan does any harm at all. There has been some hysteria lately about the contrast that you use for the MRI scan. So typically for the MS protocol, we used to give people contrast, a dye called gadolinium. This was part of our protocol. However, some person somewhere showed that if we give you gadolinium, especially people with MS that have so many scans, that the gadolinium can accumulate in the brain or maybe some other organs and maybe cause some damage. There is no evidence that it causes any damage at all. The time you should absolutely avoid the gadolinium in the MRI is if you're allergic to it, obviously, or if you have kidney problems. Then you cannot take gadolinium. Outside of that, gadolinium is probably safe. However, because of this finding of gadolinium in the brain and other organs, we don't routinely do gadolinium. If we're doing a routine MRI scan now, we don't do gadolinium. So for routine scan, no gadolinium. For diagnosis, gadolinium, yes. If you have an active lesion and we're looking for activity, gadolinium, yes. That's when we'll do gadolinium. Otherwise, we no longer do routine gadolinium. Now, early on, we do scans more frequently. So we might do a scan at the beginning. We might repeat the scan 6 months later to see how you're doing, and then maybe another 6 to 12 months after that. And early on, we'll do scans more frequently. As time goes by and someone is more and more stable, the frequency of the scans becomes less and less and less over time. And to some extent, insurance companies also, we have to fight them in terms of how many scans we can do. But the answer is early on, when the disease is more active, we're going to want to do more scans. And later on, as time goes by, the frequency of the scans will become less often.
Any other questions? He said his. Well,
I was asking about the contrast, but how does that work?
How does it?
How does the contrast work?
You mean the mechanism of action of it?
Yeah,
Actually,
yeah.
The science.
Yeah.
Wow, deep science question. Yeah, the way that it works is based on the fact that if there is MS activity, let's say that someone has a relapse, which means if you were able to look at the brain where the relapse is occurring, an inflamed area, in an inflamed area, the blood-brain barrier is broken down. So between the brain itself, the brain tissue itself, and all the blood vessels surrounding the brain, there is a barrier. It's called the blood-brain barrier. And it's hard for things to penetrate that barrier. It's a very tough barrier, and only specialized things and specialized pathways can pass it. However, when there is an MS activity, and there's an MS lesion where it's inflamed, the barrier breaks down, and the gadolinium can pass through it, and we see it light up at that point. So gadolinium is based on the breakdown of the blood-brain barrier, reflecting inflammation at that site.
Even if the lesions are in the spinal column?
Yes, same thing. The spinal column has a barrier the same way.
Okay. How do you feel about 1.5 magnets versus 3.0 magnets in an MRI?
I mean, theoretically, the higher the number, the more detail you'll see with the magnet. In experimental situations, in some research, they even have 7 Tesla magnets. But a 3T magnet is generally going to show a little more than a 1.5 T magnet. Most of the magnets most scan centers and most magnets that I've worked with are 1.5 T. And if someone's had a 1.5 T repeatedly, I like to try and keep them doing the same scan so you can compare information. If you've done a 1.5 T routinely and you do a 3T and see new lesions, you are establishing a new baseline. So if there are some new lesions, if they don't correlate with any new symptoms, I make note of them. But they don't always mean that there's progression of disease because the scan may show more detail. So it's what you work with in your center. We work mostly with 1.5 Ts, but I think 3 Ts show us a little more information. I don't think the benefit is that much greater than what some people think about it. I think in a good 1.5 T, you can get a lot of good information too.
Excuse me, we have a question over here to go back to that.
Sorry. Well, you just brushed on the topic, speaking on what George said about contrast, the sheathing, the myelin. How much, I think we've spoken in your office, how much study has been done on myelin recovery or myelin repair by the industry itself?
I mean, it's ongoing. So MS, if you want, you guys are really into some science here. So we'll talk about some science and a little bit of neuropathology. But basically, let's start with what MS is. MS is a disease of the immune system. So it is a disease in which your immune system is normally protective. It is a police force that protects us against foreign invaders, such as inflammation, infection, potentially even cancerous cells that might form in your body. The immune system recognizes them as foreign and eats up these cancerous foreign cells. In the case of MS or other autoimmune diseases, the immune system breaks down. And instead of these lymphocytes, white blood cells in your body recognizing your own tissues, they become autoreactive. They react against us. And these immune cells attack the nervous system and primarily start to attack myelin and cause some damage to myelin. If the process, and so you would see an area of inflammation where myelin is damaged, and if the process continues, it affects the nerve fiber itself called the axon. If the axon is damaged, this damage is permanent and the axon never recovers. If myelin is damaged, potentially there could be some recovery. So what you might have is that you might have some damaged myelin. If you're lucky, the axon is still there. Myelin is important for the conduction of the message along the nerve. So if the myelin is damaged, there'll be slow conduction, but may still be some function. So what can we do to help myelin? How do we help myelin? Yes, there are industry studies going on. There are substances that may promote myelin to regrow. There are also inhibitory substances in the system that prevent the myelin from regrowing. There is a substance called lingo which slows down myelin. Myelin is made by a cell called an oligodendrocyte. It's one type of cell in the brain and nervous system called an oligodendrocyte. It makes myelin, and it could be blocked from making new myelin. And so we have now a substance in research that blocks the blocker and will potentially help myelin regrow. That's called anti-lingo is the current study. That is one drug by Biogen. Biogen has another drug going into research to promote remyelinization. And there are other companies also have other drugs to try and promote regrowth of myelin.
We have a question
How close are
back
we
here.
on that? How close are we?
Hang on, we got a question back here.
Okay.
Oh, not really a question. I just wanted to mention something, and I tried stem cell treatments. I went to Panama, umbilical cord stem cells, and first time I tried it, it was almost like magic for six months. Almost, I hopped off the table, and I was using my 2 sticks, and after 2 or 3 days, I was walking around without the sticks. It worked for about 6 months, and then the body, I think it takes over the stem cells and does a number on them. But I tried it the second time, and the second time I didn't have as much positive results. What I'm looking for is if anybody knows anything about remyelinization, and is there a possibility, or is anything being researched? How far down the road is it? That kind of thing.
Dr. Steingo.
Yeah, I mean, you know, you want to talk about stem cells now? It's somewhere in your list over here. We can talk about stem cells now. I mean, there's real stem cells, and there's stem cells that are not considered by mainstream neurologists as real stem cells. So the real, and I'm happy to hear that you got better for 6 months, and whenever anybody says to me in my office they're going for stem cell treatment, I wish them well, and I say, where are you going? And sometimes what I'm saying to them is you could consider this to be a transfer process. What you're doing is transferring your money from your bank account to their bank account, and that's about the most benefit you're going to get. Most of the benefit from many of these stem cell things is placebo benefit. So let me give you examples. There is absolutely no evidence whatsoever that embryonic stem cells helps. There's none. No evidence that it helps for people with MS. Now, they are doing some study on mesenchymal stem cells where they take fatty tissue and give you the stem cells of the fatty tissue. There is, to date, no evidence that that works either for MS patients. Both of these are very experimental. The only stem cell treatment that has been shown to work MS, and of this there is no doubt, is called HSCT, hematopoietic stem cell therapy, where we take out your own stem cells. We extract them from you, your own stem cells, and we do something to them, we treat them. Now, at the same time, we're preparing your own stem cells. Why? Because we're going to do something to destroy your natural white blood cells in your body. We're going to destroy them because they reacted against you. And if we destroy them and you've got no white blood cells, you're in trouble. You could have a bad infection and die. So now we take the stem cells that we've taken out of your body and we inject them back into you. And so now you've got new stem cells, and they're going to grow. And they are going to reboot or remake your immune system. And we're hoping when your new immune system is remade, that the cells that generate are no longer autoreactive. So that's what we're doing. The stem cells for MS, the purpose of them, HSCT, the purpose is to reboot your immune system. The purpose is not to regrow myelin and help your nervous system. That is not the purpose. These stem cells do not do that. They do not do that. I had one patient who had some stem cell therapy for her knee and told me the doctor said, probably as a side effect of that will help her MS. And I said, you must run from there as fast as you can, because that's absolutely false and fake news. It's not true. It's just absolutely not true. People are desperate, though, and they try things like this. But HSCT, hematopoietic stem cell therapy, in the US, the major person who's done this is Richard Burt at Northwestern University in Chicago, who now is on some kind of sabbatical. But there is James Bowen in Seattle who has done some of this work. There's some work in other places now. If you want to look up HSCT in the US, that's what you look up, HSCT. Now, they published a paper between Richard Burt and other groups in Europe and Argentina and Scandinavia. There were 4 of these groups who got together and published their results on HSCT, and the results now are much better than they used to be. It was effective. It was good. In the old days, if you go back a decade or more, when people had therapy, what used to happen is that they got infections and there was a certain death rate. Now this is a much lower death rate. We're able to deal with stem cell therapy much better. So what you need to look up is HSCT. If you're looking up stem cell therapy
for people, or is it
in
still
the US,
experimental?
it's not covered by insurances in this country, unfortunately. There is a group in Mexico City, well-trained group. And there are people that have traveled to other countries to do HSCT.
Okay, Joe, you got the next question.
Let's talk a little bit about healthcare team and communicating with them. And I know that you have this nifty handout. You want to talk about that and tell
Yeah,
people what that is?
Obviously, communication is important. And in our office, we have a portal, and probably most of you go elsewhere have portals with your office. I know the Cleveland Clinic has a portal, and a portal is like tweeting. Personally, I don't tweet or Twitter or do any of that stuff, but it's like that. It's like what I think that is. It's meant to have a short message. So if you have a message to communicate to your neurologist, a question about a medication or a lab result. For example, if someone's had a blood test for whatever drug they're on, I'm monitoring their blood or their urine, I can write back to them if they're on the portal. I can say, blood test fine, lab clear, whatever. I can write to you in a question of in 32 letters or 5 words, short things. If you have a problem, you can write to me a short problem. Tweeting or writing on a portal never replaces a visit. But it's a good way of communication, keeping up to date in a shorthand way. So portals are very important. So communication in that way is very important. In our office also, those who do come to my office know, and this is available on the internet, we have this sheet which we call the Land of MS. It asks a whole bunch of questions, like it asks you for all your symptoms. And you should fill them in when you come to your doctor's office. If you come to your neurologist's office and you produce this, that I can still look at this. I can look at this in 30 seconds and get a good idea of how you're feeling, what your questions are, and what we need to discuss for the visit. It helps us direct the visit. It improves the quality of the visit tremendously. This is a 2-page form. And so if you write on here your questions, your symptoms, it helps me tremendously. It helps make the value of the visit much greater. At the bottom it says medications. This is the lazy section. This is a section I have no idea why, but people don't like to fill it in. I don't know why. They put things in here. You know, I've told you 100 times, what words do they write for list all medications? Same. That's great. Same. Unchanged. No change. The best one was somebody wrote yes. Somebody wrote a list of medications, they wrote yes. I mean, so now let's say I'm saying, have your medications changed? I wish I had $1 every time someone said yes, because I wouldn't retire. I'd give it to the MS Society or MS Views and News or somebody and donate it, or buy a Bentley or something. But let's say I asked you that question, what's changed? I'm saying almost always something has changed. Maybe it's not your MS medication. It might be a hypertensive medication, a diabetic medication. There's frequently a change. Just bring a list. The patients really help me the most. Some people actually print it out and stick it on, or they'll print it out, or they'll do it in a computer and bring a list of your medications, because we can look at them, get an idea of your medications and interactions and things like that. On the second page, we ask you about what I call psychosocial questions. How are you doing? How's life? How's life treating you? How about work? How's your family? Do you need help? Do you need us to contact the MS Society to get you some help? Do you need a social worker? And how is your general health? We ask all these questions. Sometimes these are the most important things that come out, really, is page 2, when someone will tell me about some social problem, and it comes up, and I look at it, and I will bring this up, and they may be most distressed about some problem in life that hopefully we can help them with, or we'll find a social worker. So it's very important. This over here is on the internet, in MS Views and News. I don't know what you call this, Stuart, exactly, in MS Views and News.
You know, it's very original. We call it the Land of MS. The Land of MS communication tool.
It's a communication tool, yes.
But I mean, if you do this, and you don't, the best thing to do is not, and this is the other thing, is you can do it when you come for the visit. So if your visit is at 9 o'clock and you come in at 9:02, which is a common time of arrival, unfortunately, and now you have to fill this in. So by the time you're done, it's 9:18 and a half, and I mean, you're running late. And you're agitated, and I'm agitated, and the next patient's agitated, and the whole world's agitated. Even Donald Trump's agitated. Everybody's agitated because of this. So what we ask you to do is fill this in beforehand. When you leave, if you're in my office, when you leave, take it with you. Or go on the internet a few days beforehand, a week beforehand. Look at this form and fill it in. And then you come in, and I look at this. I can look quickly because I'm used to these things. And I can say, oh, now let's see, you're doing pretty well today. Now I'm happy about that. That's nice. Or I can see over here, well, you have, in fact, we need to talk about your bladder. And to avoid the door question. And I'm repetitive in that too, because you know what I mean by the door question. Who knows what the door question is? Wait.
Sorry. It's when the doctor's about to leave the exam room and you go, oh, one other thing.
That's the door question. It's when the visit is pretty much over. We spent a long time talking, and oh, I forgot to ask you about my bladder. Now, the bladder in MS is not a simple topic. The bladder in MS is a complicated topic and a very, very important topic. One of the major causes of morbidity or illness or sickness or death in MS patients is bladder problems. So it's very important. So if there's a bladder problem, it needs to be written down, not waiting for the door question.
So for those that don't know, you could go to the website. You could actually fill it out on the website and not have to write, and then you just print it and bring it with you to your next neurology appointment. There's a question that came up in the back of the room that unfortunately we skipped over when you were on the last topic, and they wanted to know what's in the pipeline for remyelination as far as drugs that are coming up.
I mean, we kind of spoke about that. I said it's all research. For remyelination, there is no FDA-approved drug. There are drugs in research. There are a few clinical trials. I know of 2 clinical trials in the U.S. There might be others overseas.
Are those stage 2 or stage 3?
There is a stage 3 clinical trial for remyelination, so that's at least 2 or 3 years away. Most of them are still stage 2 trials. So there are several trials. There's no drug that is closer than 2 to 3 years of approval for remyelination. But they're coming. I mean, in 1992, we had nothing for MS, and now we have, with all the generics and stuff, 20 medications. Drugs for walking, drugs to improve bladder function and fatigue, and we have a lot of things now that we never used to have, better understanding of this disease.
Let's find out how people manage their MS. Are there any tricks that people use that you know of, Dr. Steingo, or maybe somebody in the audience has a particular trick?
Yeah, they are. You ask them. They're the people that are experienced. I mean, it's what I told you about MS. MS is the ultimate, is a team disease. Everybody must be involved. The neurologist, the team, maybe other physicians. You might have a urologist, an ophthalmologist, and a psychiatrist, and other physicians, social workers, physical therapists is a team. People that have good family support. I pray that everyone has that, but good family support is very important. They have studied that very well. The people that have good support in the family definitely have better outcomes than people that don't. So that's also important in doing well. And then recognizing everything else that goes on. So that's recognizing treating the disease, treating the symptoms, and the self-help aspect, which is what you do yourself together with your family. We've spoken already about, and I would speak about this ad nauseum forever because it's so important. Physical exercise, mental exercise, the diet that you eat, and some believe diet's more important than others. But all these things that you do for yourself are very important as well, those 3 separate, distinct, but intimately related categories.
Question here. Why do you want to grab the mic?
Okay. You had stated that bladder is a common cause of death. Could you elaborate on how that is the cause of death?
Yeah, I said that bladder is just the importance of the bladder being the door question, one of the prototypical door questions of someone not talking about their bladder. Even now, there are people that are like embarrassed to talk about their bladder. Excuse me. They'll paraphrase. They'll say, excuse me, talking about their bladder or their bowel or sexual function, which are all very important topics in someone's life. The bowel, often people will say, excuse me, when they talk about their bowel. You don't have to excuse yourself if you talk to me or your neurologist about that. That's why you're there. You know, we're not writing it on the internet. We're just listening to you and trying to help you because these are very important life-altering problems. But the bladder, what can happen with the bladder is basically very straightforward. You can get infections. So people that can have bladder problems and get infections, an infection in the bladder, if untreated, if they have recurrent infections, can eventually lead to damage to the kidneys, for one thing. A bladder infection can spread into the blood and make someone septic, so particularly in patients that have more severe MS, are more disabled. Bladder infection can lead to sepsis, and sepsis can lead to death. So that's an extreme. Most times these days, hopefully, we will diagnose it in time and treat it in time, but that is the way a bladder problem could have a bad outcome.
How about you guys out there? Anybody have any tricks for your memory? Do you do anything in particular that will remind you to do something, take a pill, or remind you of an appointment or a phone call you have to make?
Wait, somebody's got to say something. I got to get to you.
technology. Just put it on your phone calendar. And it'll ring if you want it to ring a day before.
Do you do that?
Yes?
And does it work for you?
Yes.
Okay, great. No more pencil and paper.
Nope.
Anybody else?
I have so many alarms.
He doesn't know to wait.
Minaj, you have to wait.
He's the one that wants to grab the microphone, too.
No, what I was saying was there were so many alarms and things that's on my phone that just goes off. It's a reminder to do everything. Even exercising. One day, that's actually on my phone. I even put that in our group where people need to start doing things. We always talk about things. We want to see people to do things. So I thought I could do it myself and show everybody else in our group to start doing it. And many are doing it. That's a good thing.
Do you find that with so many alarms, you just sort of start to ignore some of them? Because it's always ringing.
No. Well, if I do ignore them, my wife does know about those things. And she's the person that actually put those alarms in my phone. So, no, I try to do them. I try not to cheat. I even make these notes and things in our group pages about all these different things I'm doing. And it may be boring to some people, but what do you think? Do you think it's boring if I put out all those detailed things on the page?
No.
Thank you.
What do you think, Dr. Steingo, about the benefits of seeing a neurologist in a comprehensive MS center? What are the benefits and what is an alternative if there isn't a comprehensive center?
I mean, this disease has dramatically changed from the time of, beta serum, as I told you, was May 1993, it was approved. So we've had drugs, with the generic drugs, we have 20 medications. These medications are working on the immune system. They have side effects, powerful side effects on the immune system, potentially in other organs. Someone has to know, and there are so many of them. I think a busy neurologist in a general practice can handle a routine MS patient that is uncomplicated and has relatively mild MS. But for an MS patient with a more severe disease on a more intense drug, I think they should see an MS specialist who understands this medication. That's all I do, and that's all MS neurologists do, is learn about MS and know about all the drugs. If you go and see a general neurologist, he has to know about migraine and dizziness and strokes and headaches and a bunch of other things, Parkinson's disease. How much time is there to learn about the details of these new drugs? Difficult. So I think everybody, now I do see patients come and see me from further afield, like Port St. Lucie, and I tell my patients who come from further away, always to have a local neurologist, and then work, and I may consult once a year, or consult with their neurologist, and we'll work together. So, but in other words, to have a team. You can have a specialist MS neurologist that you may see once a year, and a local neurologist who can work together. And many local neurologists are prepared to do that. They like to do that. They like someone to help them, through this maze of MS. Some of them will say, no, you pick. You either have me or you have them. That's stupid. Then I said, you go and find a new neurologist.
And
go
what
find somebody
about
else.
other practitioners, not just neurologists? Do you think it is beneficial for people to have a one-stop shop where then they're getting their therapies in the same location? Or does it not matter so much?
It depends where you live. Here in South Florida, there's no such thing. I mean, even if you go to bigger MS centers, if you go to the University of Miami with Dr. Ramahan, and you want to see other people in the group, he still has to refer you to a neurologist somewhere and this one somewhere. So there are some comprehensive MS centers where everybody's in the same building, so to speak. But for most places, we have our referral sources. And because of the way we're on South Florida, our referrals are diverse. If you come from Port St. Lucie, I'm going to have to send you to a urologist in Port St. Lucie. If you live in Fort Lauderdale, I'm using a different urologist for the most part. So I have to have my referral people that I work with. But and there's no such thing. Somebody said, give me the name of an internist or a primary care physician who knows about MS. I said, there is no such thing. Your primary care doctor needs to take care of your general health. your heart and your lungs and your general health. If there's an MS question, what you need is somebody as a communicator. They need to call me and ask me a question. That's all they need to do. How far am I away? Here's the phone. Hello, I'm right there. This is one of the favorite things that I get. My doctor said, will you call him? I had no problem calling him. Here's my phone. Give me his number. Why doesn't he call me? You call me. I'm on the phone. I answer it most of the time. Not always, but... So there should be communication between people. Like we talked about communication of someone with MS with their medical team. Similarly, your medical team should communicate together. When you see the neurologist, you say specifically, please send my report to Dr. Smith. Ask me to do that, because if you don't tell me, I have no clue that you want Dr. Smith. And Dr. Smith should have the report. He should. Your primary care doctor should know what's going on. But tell me, just say it to me. Guess what, how long it takes to get to Dr. Smith? You know how long it takes you to get from my office to your car or truck or bus or motorcycle? How long does that take you? 2 minutes? That's how long it takes me to send a record to Dr. Smith. It's electronic. So for depending on how someone does it, I like to type notes. Some people dictate notes. It's quick. We just press a button and we got the person's name and the record goes, and they should know what's going on. They shouldn't have to say, well, what happened? I don't know what's going on with this, or what drug you're on, or whatever. So that's the communication at every single level should be taking place.
So question, going further about this, do you recommend to your patients that when they see other doctors, to make sure that their doctor or nurse practitioner from elsewhere is using electronic records?
I mean, it's encouraged by the medical system and payers and everybody that everyone should be using electronic records now. So most people probably are, but not all people are. But certainly if they're using electronic records, then you tell them, please send my lab to my neurologist. And, about 10% of the time they do. I mean, they don't often do it. The communication is not great. I constantly have to call, and Melissa has to call somebody to get our records, to get records, lab, things like that. Quest is good, by the way. If you do lab at Quest, it's very good. Quest will give us lab. LabCorp, no. LabCorp, we have to struggle to get it. But Quest will give us lab. But it's important. You say, just like you expect me to send the record, I want other people to send me the record. There are still some people who have written records. Then we can ask them to fax it. Fax the record. Fax the lab. It's particularly lab that I want to see. So fax the lab, fax the record, fax anything that's relevant. So if you can't electronically send it by fax.
Next question.
Do you think that falls on the patient then to follow up with the doctors to be sure that the reports or the visit dialogue, whatever the journaling is communicated?
Well, unfortunately, to some degree it does, because you're part of the team. The patient is part of the team. But pretty much, as I said, if you say to me, somebody saw me today and said, will you send the record to, I had to send a record to a neurologist in Port St. Lucie. And she said, I have an appointment by next week. I said, you know what, the report is there already. That's how quick it takes. You just have to tell me. But on the other hand, there are people that come and see me and I say, when did you last have lab? And they're on a drug where I need to monitor their blood count. Because if their white blood cell count is low, they could have a complication. I need to know the white blood count. So when did you last have it done? Oh, I had it done last month. The doctor said they'll fax it to you. Well, I don't have it, of course. You ask when you're there, but they still somehow it doesn't get there. Then we have to call. It's phone calls. It's wasting time. It's this, it's that. So yes, I think you should ask them. I always say to people, carry a card, give them a card, let them fax. Just encourage them. Sometimes people can call right there in the office. So yes, you have to help us sometimes, for sure.
Does anybody have any comments that they want to add about anything?
Are there any new drugs that should be considered that are just coming out, even if you're stable, or stick with what works?
Yeah, I mean, if you're stable,
yeah.
So if you're tolerating the drug,
but there's new drugs.
If the drug is safe,
new drugs with less side effects, maybe.
Let me give you the 3 points that we look at. 3 things you look at with your drug: is it safe? Is it efficacious, meaning does it work? And is it tolerable? Those are 3 things that you look at every time. And if those 3 things are met, there is no reason. If the drug is safe for you and it's tolerable and it's efficacious, meaning it's working, that's fine. Now let's talk about safety for a minute. Maybe you're on a drug that long-term potentially causes some side effects. that we may have to monitor, or the side effects increase over time. Then it may be time to look at a new drug. But if a drug meets those things, that it's safe and we're able to measure the safety and it's efficacious, it's working fine, and you can tolerate it, I wouldn't necessarily change unless something spectacular comes out. There's no such thing. There are always new drugs. Just this past year, there are at least 2 new drugs that came out. There are more drugs coming. There's at least another one probably going to be approved soon. Within the next year, we could probably have 2 more drugs. There's a lot of them, and they tend to have some advantages. If you're completely stable, we might not want to change anything unless the drug, even though it appears safe, that we know with time it becomes less safe, then we might talk about a new drug. Remember, the new drug might not work for you. No drug's a cure. So if the drug worked for you and you take a new drug, there's some risk that it might not work. This is always something we have to think about too. That's why we look at those things always. Safety, efficacy, and tolerability. And then the other one is cost. Sometimes insurance companies force our hand. We fight them, and mostly we fortunately can win, but sometimes we lose and we have to change someone's drug because of someone's stupid plan.
Okay, let's thank these two for giving their dialogue. Let's thank Jill and Dr. Steingo, okay? And then, don't leave. Now we're going to do a few minutes of Q&A, right? We're only going to do about 15 minutes of open Q&A, only about multiple sclerosis. We don't want to hear about the political system or whatever else is going on in this world. Yeah, you could giggle, all right? Does anybody have a question for Dr. Steingo? And please wait. Raise your hand in advance so I know where to go, and I will be there shortly. I'll be there in a minute. My hand on the mic.
Hi, I was wondering if you could speak a little bit about the use of supplements like the omega-3s, vitamin D, in your treatment plan for multiple sclerosis.
Okay. Supplements in general are overused and overbought. The best example I had was a patient who came to visit me with a bag, like a big bag of supplements, and I said, "How much are you spending on this?" And she said, $200 a month. This is ridiculous. And she actually was a physician. Amazing. I couldn't believe it. But there are certain things that we know about that are probably beneficial in MS. The first one is vitamin D. Now, there even are now some people who write, when you read, because there's 2 sides to everything, that it's not proved that it helps. But in everything I've read, vitamin D is very important from a young age. In fact, from the age of being a fetus, there are some studies that show that when they looked at mothers who were pregnant and then looked at their children, so they looked at women in Scandinavian countries, they looked at women, because in Scandinavia it's national health, so they know everything about you from the time you're a fetus. And they looked back at the records of these women with MS and looked at their mothers' pregnancies and their mothers' vitamin D levels. And the woman whose mothers had low vitamin D had a higher risk of MS. So vitamin D is important from a young age. It's important as you start reaching the age where MS becomes important in your teens. So that's definitely an important thing, is vitamin D as a supplement. And then B12 is an important, very important supplement for the nervous system in general. B12, it's important for everybody, for their nervous system. So if you have a nervous system disease like B12, it's also very important. So those are 2 supplements, B12 and vitamin D, I think, that are proved to be important. Now you can do a whole bunch of other things and read up about, if you went on the internet, you could find 100 supplements that someone recommends and sells. I don't know if there's great evidence for those, but B12 and D are important. Now if you go back and look at the Swank diet, for those who know Dr. Swank, he was the person that really, a pioneer in MS studies and research, worked in MS many, many years ago, wrote the Swank book and the Swank diet, and worked until he was 87 years old and died at the age of 99. Whether it was because of his diet or not, I don't know. But he said people with MS should avoid saturated fats. And if you're avoiding saturated fats, then in your diet, you need fat. Fat's crucial in your diet. You can't avoid fat. You need fat. But you should concentrate on unsaturated fats. Where do you find them? Omega-3 or unsaturated fats. You find them in nuts, certain oils, certain vegetable oils. You find them in certain cold water fish, like salmon and things like that. So that's where omega-3 would come in unsaturated fats. So I think that's the main things you need. There are 100 other things you could read about, CoQ10, turmeric, curcumin. There's no great scientific evidence at any of those. I don't think, if someone asks me about those, I'll say I don't think they're going to harm you, but the science is not there to say that they're going to do you much good.
So is this on? It was on?
Not right now. I got a big mouth, though. I'm telling you, you can't do that. So
okay. I've got a question regarding statin drugs. there's been a lot of information lately that they can cause weakness, pain, ataxia. I wonder sometimes, because I'm on simvastatin, by the way, my cholesterol is great now, and I wonder sometimes if I shouldn't just get off this stinking drug and see if it's going to have some effect on my MS.
Statin drugs and MS, somewhat mixed picture and complicated. So, for example, statin drugs have actually been used to try and help MS. And there was a study that showed that statin drugs helped progressive MS. However, the dose that was used was a very high dose. For example, 80 milligrams a day, that level of dose. So I don't think in that way statins help. How else can statins help? We know that people with MS have a higher risk for cardiovascular disease. Sorry to tell you that. If you don't know that, I'm telling you that. If you look at young patients, young women, particularly starting out with MS, at the beginning, their risk of stroke and vascular disease increased. And over time, there is still an increase, although it may become less over time. But people with MS do have a higher risk of cardiovascular disease. So they may need, if their cholesterol is high, they may need to pay attention to and take a statin. So overall, from the metabolic standpoint, I think statins are good. From the metabolic standpoint, they do very well. But they do have some side effects, exactly like you're saying. They can cause weakness, muscle aches and pains, even neuropathy. There's no doubt they cause some side effects, some other metabolic side effects. But in general, on balance, I think most cardiologists, most people that are experts in statin, I'm not an expert in statins, most people that are experts in statins would favor that the benefits are much greater than the side effects. But if you have MS and you've got a lot of, and you started a statin, you've got a lot of muscle aches and pains, you can hold the statin, stop it, and see what happens to your aches and pains, so you'll be able to attribute what symptoms are from the statin and which may be from your MS.
Okay.
You had mentioned that exercise is important. Is there any particular exercise that you recommend and the frequency?
I would say any and all exercise is important. There are certain things you're going to hear from Jeff after I'm done. You're going to hear from Jeff. He's an exercise expert. He's going to talk to you about that. And I've said all exercise and keeping active is important. The most important things for exercise, number one, from my standpoint that I stress, is safety. Make sure for a person that they're doing safe exercise. So when you learn from your therapist about exercise, they need to be safe. And secondly, exercises that you can do. So if someone teaches you exercising and they fatigue you and they're tough and you feel horrendous after the exercise, you're not going to continue with it ever. You need exercise that, what I want your exercise to be is a habit. We acquire bad habits very easily, like smoking and other things like that. But you want exercise to become a habit. Except it's a good habit. Just like you got a bad habit, you can acquire a good habit. And so your habit becomes exercise, whether it's 5 minutes a day or 10 minutes. So I want exercise to become a habit. I want it to be safe. I want you to enjoy it. Do exercises that you look forward to. And then it's going to work. And that takes time to acquire that. That doesn't happen overnight. That takes time to acquire that.
Next question over here.
Can you address some of the issues around diet? Like, gluten, staying away from gluten is very important. And
see him do his Spock? See his eyebrow come up?
Diet is, for me, a very favorite topic, so I'm going to summarize it for you because I could speak all night about diet. Some neurologists think diet's very important, and some say there's no scientific evidence and they don't think it's important. But I think diet is important. I've already mentioned one fact, or two facts. We mentioned, for example, Dr. Swank, who wrote the Swank diet and said that people with MS should take preferentially a diet that is, avoiding saturated fats and concentrating on unsaturated fats. Some people propose that gluten is a poison for MS. Dr. David Perlmutter, for those of you who want to read about gluten, David Perlmutter has written a bunch of books. He's a neurologist who wrote a bunch of books and retired. And he wrote a bunch of books on gluten. He thinks gluten causes all the ailments in the world, MS, Parkinson's, Alzheimer's, autism, everything in his eyes is due to gluten. And he'll write a lot about, if you want to read about gluten-free diets, David Perlmutter's books on Brain Grain, Brain Maker, I think his latest one's called Brainwash or something. All these books tell you about low gluten diet. I don't think there's, again, not strong scientific evidence, but if someone wants to try it, I encourage them. I say, you feel free to try a gluten-free diet, see how you feel. And people do, and they say they feel great. I don't know how and why it works. As an example, in my own household, My wife, who thank God is quite healthy, decided to go gluten-free for some problems that she had, which were not health problems. There were some other problems she had, and she claims it helps her. I don't know why, but it does. So gluten-free can help some people, and it's worth trying. Scientific evidence is not great, but you can certainly try gluten-free. I always recommend for people to take a plant-based diet. That doesn't mean you have to be a vegan or a vegetarian. If you want to eat meat once a month, red meat, that's up to you. So people are vegetarians for two reasons. Some of them are vegetarians for ethical reasons, because they don't want to kill animals, because of the barbaric treatment of animals. And some people are vegetarians because they believe in it for health reasons. And some are for both reasons. So what you can, here is a reference that you may read, and I recommend it strongly, is Blue Zones. And if you're not familiar with the Blue Zones, you should be familiar with it at the end of tonight when you go home and look on the internet. The Blue Zones was written by a person who was hired by National Geographic to go to areas of the world where people live the longest. And he said, why? And it was because they had plant-based diets. Why? Not because they didn't want to kill their cows and their goats. They couldn't afford to have meat, and they ate a plant-based diet. So that's what the Blue Zones is. It says you can eat some meat if you want, some chicken and some meat occasionally, and fish and things like that. But your diet should be a plant-based diet. So that is what I recommend for diets, are plant-based diets.
Last question, right here.
What is your feeling on artificial sweeteners?
They're artificial.
Yeah, I mean, some of the artificial sweeteners I think metabolically are no good, such as, so the one that I think is okay, there's only one artificial sweetener that I would agree with, and that is stevia, which is directly plant-based. As regards all the others, I think the evidence for the others, there's all kinds of stuff you read on the internet. They cause migraine, they cause cancer, they cause this, they cause that. I think what they do, though, is that they affect your microbiome, which is the bacteria that are in your gastrointestinal tract. Your gastrointestinal tract, which lines from your mouth to your rectum, the gastrointestinal tract is the biggest single site of your immune system. And these, I think, artificial sweeteners have adverse effects on the gastrointestinal tract. And so I do not recommend them. I recommend stevia. If you have to put some sugar in, I think an artificial sweetener is probably better than sugar, which is a poison. But in general, I'm going to say if you need artificial sweeteners, stevia is the one that I think is okay.
Thank you, Dr. Steingo. Let's give him a round of applause,
Okay,
please.
thank you. Woohoo.